Om Dham Dhanvantare Namaha. Karpura Gauram Karunavataram Samsara Bhujagendraharam Padavasantam Hridayaravinде Om Bhavani Sahitam Namami. Let me share. So, topic is bronchial asthma, pathology and diagnosis. Bronchial asthma is a condition where there is characterized by breathlessness more than 3 months, and there will be cough and expectoration. So, underlying pathology in the tissue, there will be changes in the alveoli and the bronchial tree. There is some changes takes place due to the inhalation of allergen or food allergy. The mast cells present in the lungs, they will secrete histamine, bradykinin, etc., leukotriene, etc. These are the inflammatory things, and histamine will increase the permeability of the bronchial vessels, leading to excessive perfusion to the bronchioles and excessive secretion of the mucus, and also causes constriction or contraction of the bronchial smooth muscles, leading to spasm of the bronchioles. This will lead to plugging of the bronchioles, and there will be airway obstruction and dyspnea, difficulty in breathing. And due to secretion, more secretion, there will be congestion. So there is a histology of the lungs. You can see the bronchioles. Bronchioles are lined by pseudostratified columnar ciliated epithelium. Under that, there will be smooth muscles, submucosa. After that, smooth muscles will be, and these smooth muscles responsible for bronchospasm in asthma. There will be cartilage of the and the outermost covering. In the alveoli, you can see respiratory membrane is there, epithelial, made up of epithelial cells, endothelial cells, membrane. This is also, again, in the center, you can see bronchioles. There are alveolar sacs. See. So, histology of asthma characterized by a number of structural changes, including epithelial detachment, mucus gland hyperplasia, subendothelial fibrosis, inflammatory cell infiltrate, bronchial smooth muscles hypertrophy, and vascular changes. So, in the bronchiectasis, emphysema, compliance and destruction of alveolar walls, proteolysis of connective tissue components, including elastic fibers within the alveolar walls, increase in the compliance of the walls, they say in the emphysema. So, in bronchiectasis, histological changes in the bronchiectasis include cartilaginous destruction, fibrosis, mucosal and mucus gland hyperplasia, inflammatory cell infiltration, and increased mucus and exudate. Well, you can see here attachment of the mucous membrane. There will be hyperplasia, the glands, and smooth muscles, and an inflammatory exudate lumen. Here you see the lumen of the bronchioles contains exudate and mucus. Okay. So, and in asthma it is seen, and also you can see hyperplasia glands. There you can see the bronchiole. There is the hyperplasia of the glands. Mucus exudate is there in the center, in the lumen, and also there is mucus, the smooth cells of the seed. We have another histological slide showing different stages. First, you can see the exudate, the lumen. Second, you can see the training of the walls, and the third, fourth, you can see the exudate, mucus, in the center of the bronchiole. There you see the inflammatory cells, and the exudate is the lumen of the bronchioles. So here you see the bronch emphysema. Emphysematous in alveoli comes enlarged. Enlarged. So if the bronchial asthma is not properly treated, that will lead to bronchiectasis. Bronchiectasis, there will be dilatation, permanent dilatation of the bronchioles. And in next stage is emphysema. There will be permanent dilatation of the alveolar sac, alveoli. There will be exudate with the mucus exudate and repeated infection causing breathlessness. Here you see the bronchiectatic stages. Here also or the emphysema. Cycle is enlarged. Another histological slide of bronchiectasis. Another one, you can see inflammatory cells. Then coming to X-ray. Here you see the thoracic cage. The thoracic cage is cylindrical. Right? So there is increased intercostal space, and in the asthma, there is a increased bronchovascular markings are prominent. You can see the lateral 1/3 of the lung parenchyma also there is bronchovascular markings are seen, and hilar shadows are prominent. They are seen in chronic asthma. This is another asthma. Here, bronchovascular markings are prominent. So, case of bronchial asthma, here also hilar shadows are prominent. Another X-ray, the breast shadow you can see, and is a female, and the hilar shadows are prominent. Bronchovascular markings are prominent. When asthma symptoms like breathlessness, cough with expectoration. In the night time, in the evening, there will be occurrence of cough expectoration, and on an examination, there will be expiratory rhonchi. Expiratory rhonchi is a brief infection is also there. There can be crepitation also. This is another of bronchial asthma. You can see bronchovascular markings are prominent, hilar shadows are prominent. This is a case of emphysema. Emphysema findings are increased intercostal space. Second one is increased translucency of the lung parenchyma. Third one is indentation of the esophagus. Fourth one is widening of the carina, teardrop heart, and also the flattening of the hemidiaphragm, teardrop heart. These are the findings of emphysema. You can see the lungs, the thorax is barrel shaped, cylindrical. Here is the same, isn't it? You can see increased intercostal space, increased translucency of the lung parenchyma, and flattening of the hemidiaphragm, teardrop heart. vertical heart. These are the findings of emphysema. So also we can see emphysema. Right? Increased intercostal space, increased translucency of the lung parenchyma, and teardrop arteries. Here you see the bronchial asthma. The cardinal is there. Asthma is also there. Asthma is highlight shadows are prominent. Here you see white shadow is there in the right lung. Highlight shadow. Here you see bronchovascular markings are prominent. Here you see mitralization of the heart is there. Pulmonary coronus is enlarged. There is tightening of the left cardiac border. This of left atrial hypertension. Pulmonary hypertension is there because of chronic lung disease. Here you see aortic knuckle is prominent. Maybe a case of hypertension, and there is a vertical heart. Chronic. First one. Here you see bronchovascular markings are prominent, and hilar shadows. Here hilar shadows are bronchovascular markings are prominent. Increased intracostal space also there. Chronic asthma. Here you see hilar shadows are prominent. Here you see the increased intercostal space and increased translucency of the lung parenchyma, vertical heart, flattening of the diaphragm. This is the bronchioles where lumen is decreased because of accumulation of mucus as well as spasm of the muscles. This is the peak flow, peak expiratory flow rate test. That's called as peak flow expiratory flow meter that is used to assess lung capacities. So method of using the peak flow meter. This is the spirometer. Record and measure respiratory volumes. The method. So in bronchial asthma, there will be symptoms like chronic history of dyspnea, cough with expiration, copious mucoid sputum will be there, thin sputum, and there will be in the evening breathlessness is increased by dust, smoke, etc. The symptoms will aggravate. There may be running nose, also may be sneezing, also may be there. When it is not populated, it will lead to bronchitis. Bronchitis is circular, nummular types are there, and emphysema. Next stage is emphysema. Even if not populated, then it will lead to cor pulmonale, right hypertrophy is seen. Then arterial failure and respiratory failure. The course of the disease. We have discussed the histopathology of the bronchial asthma, bronchiectasis, and emphysema, and X-ray findings of chronic bronchial asthma, bronchiectasis, emphysema, and instruments which are used to measure to measure the respiratory volumes. Great. Thank you for patience.